Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series. Today's focus is contact dermatitis, a condition every primary care provider will encounter at some point. We'll dive into the differences between allergic and irritant contact dermatitis, discuss clinical features, diagnosis, management, and prevention. And of course, sprinkle in a couple of clinical pearls and questions to test your knowledge. Let's get started. Let's start off with some basic pathophysiology. Contact dermatitis can be divided into two types, irritant and allergic. Irritant contact dermatitis is caused by a direct cytotoxic effect from chemical or physical agents such as cleaning agents, detergents, or chemicals. Allergic contact dermatitis, on the other hand, is an immune-mediated reaction caused by an antigen that elicits a type 4 hypersensitivity reaction, triggered by allergens such as nickel, fragrances, or poison ivy. Both types lead to inflammation, but the underlying mechanisms differ, making accurate identification crucial for management. Who does contact dermatitis affect? It can affect anyone, but certain groups are at higher risk. For example, healthcare workers frequently develop irritant contact dermatitis due to repeated hand washing. Allergic contact dermatitis is often seen in individuals exposed to specific allergens, like metals in jewelry or chemicals in cosmetics. Understanding your patient's environment and exposures is key to identifying triggers. The clinical presentation varies depending on the type and severity of contact dermatitis, as well as whether it is an acute or chronic presentation. Acute irritant contact dermatitis often appears as erythema, vesicles, erosions, and scaling to areas with direct exposure to the irritant. Acute allergic contact dermatitis usually presents very similarly, but may spread beyond the area of contact. Chronic contact dermatitis, on the other hand, for both allergic and irritant, can lead to lichenification and fissures. A little tip is to pay attention to the distribution of the rash. It's often a clue to the culprit allergen or irritant. For example, allergic contact dermatitis due to poison ivy has a classic linear distribution. This type of presentation, with history of outdoor gardening somewhere where poison ivy is common, could be easy to identify this as the culprit. Regarding diagnosis, this involves a thorough history and physical exam. If performed, patch testing results can also be helpful to identify allergens to be avoided in allergic contact dermatitis. For irritant contact dermatitis, the diagnosis is also clinical, but based on the history of exposure to a chemical or physical irritant. Now, let's talk about the management. Management starts with identifying and avoiding the offending agent. This is critical to prevent recurrences. The first-line treatment is topical corticosteroids, and the potency is selected based on severity and location of the dermatitis. And systemic corticosteroids are indicated for acute, extensive, severe, or disabling allergic contact dermatitis. Regarding prevention, for irritant contact dermatitis, advise patients to use protective clothing such as goggles, shields, or gloves, and avoid harsh soaps. For allergic contact dermatitis, try to find alternatives to offending products such as cosmetics or jewelry. And for both allergic and irritant contact dermatitis, regular application of emollients may help maintain the skin barrier function. A clinical pearl to take with you for patients with hand dermatitis is to consider whether the patient's job or hobbies involve frequent exposure to water, chemicals, or allergens. Addressing these factors can significantly improve outcomes. All right, let's practice some questions. Question 1. A 30-year-old nurse presents with a rash to her hands that developed gradually over the past 2 weeks. She reports frequent hand washing and denies exposure to new soaps or creams. Examination reveals erythematous plaques with scaling and erosions on the dorsal and palmar surfaces of the hands without vesicles or oozing. Which of the following is the most likely diagnosis? Is it A, atopic dermatitis, B, allergic contact dermatitis, C, irritant contact dermatitis, or D, psoriasis? I'll give you a couple of seconds. If you chose C, irritant contact dermatitis, you are correct. The history of frequent hand washing points to irritant contact dermatitis rather than allergic contact dermatitis or other conditions. Question 2. A 45-year-old man presents with an intensely pruritic rash on his forearms that began 3 days after gardening. He reports contact with poison ivy. Exam reveals erythematous papules and vesicles in a linear arrangement on both forearms. Which of the following is the most appropriate next step in management? Is it A, oral corticosteroids, B, topical corticosteroids, C, patch testing, or D, antihistamines alone? If you chose B, topical corticosteroids, you are correct. The clinical presentation is consistent with allergic contact dermatitis caused by poison ivy. Topical corticosteroids are first-line therapy, and patch testing is unnecessary in this case since the trigger is known. Great job! Thank you for joining me on this episode of the Pro PA podcast. Contact dermatitis is a condition commonly encountered in primary care. Stay tuned for our next topic in the dermatology series. Don't forget to subscribe and turn on notifications so you never miss an episode. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.